All right, so thanks for the introduction, Christelle, and really happy to be here. Thanks for the invite. And yeah, I wanted to talk to you guys today about pain in rheumatic and also in non-inflammatory diseases. I'll get right into it. Some disclosures, I do have some honorariums from several of the companies there. And what I wanted to talk to you guys about today, and hopefully will be some interesting takeaways that you can use in combination with sort of everything you've learned this weekend, which is quite a bit, I see. But I'd like to start with talking a bit about pain mechanisms in rheumatic disease, why people with rheumatic disease get pain, when to suspect rheumatic diseases in your patients, focusing on three different conditions a bit more specifically with pain: rheumatoid arthritis, osteoarthritis, and fibromyalgia, and then talk a little bit about some new ideas maybe that are coming on the horizon in pain and rheumatic disease. So I'm speaking at a pain conference. I don't think I need to convince anyone here that pain is important for our patients, but I do want to highlight that it is also important in patients with rheumatic disease. And this was a study from 1983, so a while back, looking at different measures of physical disability, psychological status, and pain in rheumatic disease patients. They had found a few things that may or may not be intuitive. Number one was that pain was important to patients. They found that it was actually the most important of the three aspects of assessment in terms of explaining medication usage. And finally, and really importantly, it was found that pain was the best predictor of subsequent pain, and also most associated with subsequent physical disability in rheumatic disease patients. So how does rheumatic disease cause pain? I'd like to review a little bit about the pain pathways, and which you may have gone through either this weekend or in the past, but what I'd like to highlight is on the left here, you can see the ascending pain pathways. And essentially this is how our body perceives the outside world, right, with our nervous system. So when there's damage or some kind of stimulus in the peripheral tissue, what we see is the A delta and the C fibers transmit that into the spinal cord, up the ascending pathways, into the brainstem, and then into the brain itself. And so, as you can imagine, it's going to go into the somatosensory cortex, where we can feel what is the sensation and where is it. But it also goes to other parts of the brain as well. So it gets a little bit more complicated than that. And on the right-hand side of the screen, you can see that in a bit more detail. We see these ascending pathways going up to the brainstem and the brain, but we also see descending pathways going down to modify that pain stimulus. And this is where pain in both rheumatic and non-rheumatic disease can be further sort of sussed out a bit when it goes to parts of the brain involved in memory and mood, and as well as chronic pain or neurologic stimulation leading to changes in these descending pathways that can lead to pain when there shouldn't be pain there. And we'll touch on that a bit later on. So there's many different ways to classify the type of pain. I'm sure everyone's familiar with a number of them. One of the ways that I think fits well when I think about rheumatic disease is these three categories here. So nociceptive pain, neuropathic, and something called nociplastic pain. And to briefly go through some of that, nociceptive pain is what I think most people are very familiar with. There's inflammation or there's damage in the tissue somewhere. We can localize that. You know, my wrist hurts. And it's managed generally with treatments that we would think would be normal for pain. So painkillers, anti-inflammatories. And this is obviously the cause of pain in many conditions such as osteoarthritis or autoimmune disorders. Neuropathic pain, I think people are quite familiar with as well, but definitely a different pathology. So pain directly from damage to the nerve itself. And it presents differently, maybe in a dermatomal pattern or with numbness, with tingling, burning type of pain. And the treatment for that is different, right? So we manage with medications that work on the nervous system. Conditions such as diabetic neuropathy, postherpetic neuralgia, I think we're familiar with. And then nociplastic pain. So I think there's a number of ways that we can call this, but essentially this is pain more in the central part of that pathway I showed you guys earlier. So pain either in the central nervous system or in the descending pathways. And this pain is different. It can be widespread. It's not restricted to any particular area. And it may be associated with other things like fatigue, poor sleep, memory issues. And the classic one, I think that we'd be familiar with being fibromyalgia, but there's other related conditions or seemingly unrelated conditions that can be associated with this as well. So let's focus a little bit more on rheumatic disease and in particular in rheumatoid arthritis. So how do we get pain in rheumatoid arthritis? So first of all, quick anatomy review. We've got two bones coming together to make the joint, and there's the joint capsule surrounding that. Now the joint capsule and the synovial membrane is the target in rheumatoid arthritis. So this is where the immune attack happens, and it causes inflammation and it causes swelling in that joint. And the reason for that is very complicated, which you'll see here. And apologies for the very busy slide, and it's definitely beyond the scope of the talk today, but I do want to highlight a few things on this slide so you can kind of understand what's happening. So essentially our immune system is set up to protect us from the outside world. And in the top left here, you see what's called an antigen presenting cell. This is a cell like a neutrophil, a macrophage, dendritic cell that floats around in the body, and it finds things that shouldn't be there. So bacteria, viruses, and when it does, it breaks that down and it presents it to a more sophisticated part of the immune system, a T cell, that then goes on and communicates with many other parts of the immune system to orchestrate an attack on that virus or on that bacteria, whether it's antibodies, whether it's other immune mediators. But in rheumatoid arthritis or in autoimmune disease, this changes. And rather than a short-lived attack while we're infected, this persists, and it leads to, as you can see here, other cells becoming activated that affect the synovium, affect the bone, and affect the cartilage to cause damage. And we think that that's probable. We know that it's in part due to a genetic makeup and how our body makes all of these molecules, and also to some type of environmental trigger or second hit hypothesis. But either way, when this happens, and this immune response happens, it does cause pain, among other things. And so as you can see on the left, when that inflammation happens in the joint, we get this synovial lining that proliferates and causes damage to the bone. And it looks, from the outside, it looks like swollen joints. And so of course this causes pain. And as you'd expect, this is a nociceptive type of pain. We can tell where it is. The patient will tell you where they hurt, and you'll be able to find it on exam. But other things happen as well, and especially with chronic inflammation over time. So what you can see on the x-rays here of the left hand is that on the very left, it actually looks pretty normal. You know, maybe a bit of joint space narrowing in the wrist, but the joints look pretty good. You can't really see the inflammation on an x-ray. But as time goes on and as this inflammation persists, we start seeing the damage to the joints. We start seeing erosions. We start seeing more joint space narrowing in the joints. And then this continues to happen. Rheumatoid arthritis affects the periarticular structures as well, the ligaments, the tendons that are supporting these joints. And so what we actually start seeing is subluxations in the joints. And as this progresses further and further along, we can get fusion where we essentially lose all the joint lines, quite a bit of loss of range of motion, and disability and deformity. As you can see here, this is a classic picture of a rheumatoid arthritis patient with quite a bit of subluxation and deformity in the joints. And even at this point, there might not be a lot of inflammation anymore, but the disability and the deformity is there that can lead to its own types of pain due to changes in joint anatomy. So we're going to circle back to that a little bit later on, but I do want to cover, so when to suspect rheumatic disease in your patients. Because as a rheumatologist, I'm very unlikely to be the first person that sees the patient about their pain or their symptoms. So it's important for, I think, anyone working in healthcare, especially in a primary care setting, to have a bit of a radar up about autoimmune disease when they're seeing someone in pain. So what I find is very helpful is to try to characterize the pain a little bit better. So we learn this in med school about how to kind of compartmentalize to come up with a story that then we can make a differential diagnosis. And so what I find is helpful is to establish the pattern of the pain. So is it generalized, widespread pain, it hurts everywhere? Or is it in certain areas? And could that be in the joints, in the muscles, or maybe a particular joint? Could it be in the bones or in the lower back? And if it is in the lower back, what is that character of the pain? Is it more an inflammatory type of pain or more mechanical? And we'll talk a bit more about that. Is there pain in the muscles? And then are there systemic symptoms that don't really make sense as far as why this person is coming in? So also going back to a bit about how we approach pain in med school, I think important to be able to tell, is the pain in the joint or outside of the joint? And as you might remember, in the joint, we think that, well, any direction the joint moves is going to hurt. So pain in all or most range of motion. And it's going to hurt whether the patient moves or whether you move the patient. So active and passive range of motion. They may have swelling or tenderness over the joint line. Compare that to like a periarticular pain, say a rotator cuff, where they're going to have pain in certain range of motion, or maybe only when the patient moves, but when you move the joint, they feel okay. Neurogenic pain often comes out in the history, maybe in the exam as well, and then referred pain or other types. And I think this is one of the most important slides for, does my patient have a rheumatic disease or should I be suspicious, is if you can tell whether the pain, especially if it's joint pain or back pain, is inflammatory versus non-inflammatory. And we classically think of inflammatory pain as being worse with rest, getting better with activity, and a lot of stiffness, so more than an hour of stiffness. Whereas non-inflammatory pain, it hurts more when they move it. They feel better when they're resting, or at least that alleviates the pain. And they might be stiff, but it's not usually more than 30 minutes. So what about other things? Because rheumatology can be a big black box. It still is to me. But when might you be thinking of things like connective tissue disease, things like lupus? And I won't go into a lot of detail on that. That's a big, big topic. But when you go through that review of systems, I often just think head to toe or in a way that makes sense to you. But things like constitutional, so fevers, weight loss, night sweats, things that would tell you there's something more going on than just that pain that they're coming in with. If they have rashes that are new or different, or Raynaud's that is new. So Raynaud's commonly happens early in life, but if they're in their 50s, 60s, and it's just coming on, that's unusual. On head and neck exam or history, are they having hair loss? But that can be a common symptom. Is it scarring? Do they have broken strands? Are they having ulcers that are new or different in their mouth that are maybe painless? Are they having chest symptoms that are atypical, that are new for them and don't really fit with maybe their comorbidities? Abdominal symptoms, neurologic symptoms that especially don't improve on repositioning. So not your classic maybe carpal tunnel syndrome, but these are things that don't go away or are progressing. Or true muscle weakness, so not just feeling weak, but unable to get up out of bed or reach for things overhead. Some things not to miss would be, on the left here, we can see X-ray of the SI joints. And what we're already starting to see is quite a bit of subchondral sclerosis. We're losing the joint line, and this is classic for ankylosing spondylitis. So when you have that young patient coming in with low back pain and they never really had an injury, or maybe they did and they're not recovering as well as they did, should or would be expected, something to think about. Classic picture of Raynaud's, again, coming on later in life, is a bit of a red flag. I'm not going to talk about gout much in this presentation, but I've seen a few of these recently where gout has been missed for many, many years. And here you can see in the small joints, which you wouldn't expect normally, that we're already seeing tophi. And this has obviously been there for many, many years. This is a malar rash of lupus. So we classically see the nose and the cheeks involved, but sparing the nasolabial folds. And then finally, a rare condition, but something to watch out for, this is sclerodactyly, something that we see in systemic sclerosis or scleroderma. Hard to miss, but you need to know what it is to recognize it. And if you're wondering about some of these things, what I generally recommend is a reasonable screening test. If you're wondering about inflammatory arthritis, such as rheumatoid arthritis, would be checking inflammatory markers in the CBC to see is there inflammation there. Serologic markers like rheumatoid factor and the CCP, and then some other things to see what else could be going on, thyroid testing, a 𝐒𝐂, and getting some x-rays, even if it's as a baseline, just to see what's going on in the joints. I didn't put ankylosing spondylitis on here, but obviously if you're wondering about that in a patient with back pain, getting x-rays of the SI joints and maybe an HLA-B27. And then if you're wondering about connective tissue disease like lupus, if some of those other things are coming up on your history or your exam, getting an ANA and maybe an ENA would be something to look at as well. Okay, so we covered a bit about how do people with rheumatic conditions have pain, or why do they have pain. So let's talk a little bit about each of those in a bit more detail. So in rheumatoid arthritis, as I was mentioning already, there's pain from that kind of nociceptive standpoint. So there's damage to the tissue, it's well localized, and this is causing pain for that patient. And this is usually how they'll present initially. It can also be from chronic damage, as you saw in those x-rays. As you lose that joint space, as you accumulate damage, this is going to cause pain, but it's not from the inflammation anymore. It's from changes over time. They can get neuropathic pain as well. And so in rheumatoid arthritis, if there's swelling in the wrist, it can compress the median nerve, and you can get carpal tunnel syndrome from that. Could happen in any joint that a nerve's going through, like the elbow as well. Rarely you can get vasculitis or other things that could cause damage to nerves. So neuropathic pain happens as well. Going back to this nociplastic term, this more centrally mediated type of pain, we can get this as well. And in fact, there's some studies that show up to 18 to 24% of patients with rheumatoid arthritis actually meet criteria for fibromyalgia as well. And we think that with chronic pain over time and the changes that happen in those ascending and descending pathways and in the central nervous system, that this can lead to this type of pain in patients with rheumatoid arthritis. Other things that can factor in as well are things like education level, coping strategies, socioeconomic variables. And there are some studies that show that these factors are actually more important than those objective findings of joint space narrowing on X-ray or elevated inflammatory markers on pain and disease or pain and disability. So really important factors to consider in those assessments. So how do we manage pain in rheumatoid arthritis? Well, I highlighted this one here. It's actually critical to determine what is the mechanism for the pain. So remember, there's those different categories. And so when the patient comes in, they've had a long-standing diagnosis of rheumatoid arthritis, it's still so important to figure out, well, why are they in pain today? So if it's well localized, if you can find it on exam and you're thinking it's nociceptive, well, this could still be inflammatory or from chronic damage. And that's an important distinction as well, because it definitely changes how you go next. Is it adjusting the rheumatoid arthritis treatment, or is it managed more similarly to, let's say, osteoarthritis when there's damage to the joint? If it's neuropathic, I gave the example about carpal tunnel syndrome, we manage it differently. And then if it's more this nociplastic type of pain, we manage similar to fibromyalgia, which I'll talk a little bit more about. So one more complicated slide, just going back to a little bit, remember the mechanisms of how the immune system works in rheumatoid arthritis. Well, the good news here is that there's many things to target. So again, right from that presentation of the antigen to a T cell all the way to this orchestrated immune response, these are all targets for therapy, and many of them have been used and are used today for that. We think that rheumatoid arthritis is different for everyone. You know, not everyone's RA is the same in the mechanisms, and that's why some medications work for some and not for other patients. And so these do become targets. I think an important takeaway from the primary care setting here is that although these are complicated medications, and often, you know, you see the TV ads with a lot of these scary side effects, I think it's important to reassure patients too, because what you'll notice is we're not blocking the whole immune system here. We're taking a very targeted approach and taking out one part of that immune system. We're modifying it. And so what that means is we're not wiping it all out. Patients are still able to fight off infection. They're still able to fight off cancers, even if there's a small increased risk there. I wanted to talk a little bit about pain and osteoarthritis. I know that you guys are definitely getting a lot of that, have had a lot of that this weekend, and I think even another talk coming up, so I won't go into a lot of detail here. But I did want to pass along, this is a website that I use quite a bit, rheuminfo.com. It's made by rheumatologists, but it's got a lot of really good information. I think anyone in primary care to specialists, it's valuable for on inflammatory and non-inflammatory conditions. And so this is a handout I go through with my patients, talking about non-pharmacologic and pharmacologic treatments, and even just as a way to show that, you know, there's a lot of stuff out there. There's a lot of ways that we can manage it, and just so that they can see that, and we can talk more about it to facilitate that conversation. I wanted to talk quickly about the osteoarthritis guidelines. Again, not to get into too much detail, but often there's a question about, well, what about medications? And so the guidelines, these are the ones put out by the American College of Rheumatology and the Arthritis Foundation in 2019. And so they've gone through the evidence, and then they, of course, weigh in what is their opinion. Do they recommend or not recommend? And so on the left in green are the ones that are recommended. I think most of these we're all very familiar with using, topical or oral NSAIDs, and sort of all the way down. The ones in yellow, I've highlighted a bit differently. They're actually not recommended, or they're recommended against in the guidelines, but they're often due to maybe a risk of bias in the studies or just a lack of evidence. And so I still put them in yellow because there is some potential benefit, and we all kind of have that anecdotal evidence that maybe things that could be tried, but it's important that the patient knows and that you know that they're not technically recommended in the guidelines. On the right, these are unfortunately treatments that we haven't found benefit for and they're recommended against in the guidelines. Of note, sort of from my end of things, we have looked at disease-modifying agents, so hydroxychloroquine, TNF inhibitors, methotrexate in osteoarthritis, because we know that there's an inflammatory component, but unfortunately, we just haven't seen benefit in that. I will say that I sometimes use hydroxychloroquine in more of the erosive osteoarthritis population because we have had some studies showing benefit and there's anecdotal evidence there. But I always tell them that this is very limited evidence. We go through all the risks and benefits before proceeding. And so what about pain and fibromyalgia? So as I've been kind of alluding to throughout the presentation, this is really that centrally mediated, nociplastic, very complicated mechanism of pain. So people present with diffuse pain, it's widespread pain. They have hyperalgesia and allodynia. They have these associated symptoms that we think maybe because of how that pain is then processed higher up. So fatigue, poor sleep, mood disturbances, cognitive dysfunction. And they can also have amplification of other senses too. So auditory or visual senses can be amplified as well. Associated with prior infections in some cases, physical trauma, PTSD. These are all associations with fibromyalgia. And again, going back to the pathways, what we see is there is upregulation from these, often from chronic stimulation of the pain pathways, or for other various reasons, we get upregulation in some of these ascending pathways, and then we get impairment in the descending pathways. So the pathways that are supposed to calm down this pain response. And so a lot of the treatments, at least from the medical side, that are medication side that are used in fibromyalgia work on this. So we often are using gabapentin or other anti-epileptics. Ketamine is becoming a more commonly used treatment to help on this side. And then we often use agents working on norepinephrine, dopamine, serotonin, so a lot of the antidepressants to work on these descending pathways, again, to try to treat that pain signal. So there are guidelines for fibromyalgia as well. These are the EULAR recommendations. And so they go through a number of different treatment options. And these are ones that I think people are starting to become more and more familiar with for treating fibromyalgia. Again, antidepressants are a common one. So amitriptyline, one of the first ones I think people started using for this. And what I think, some takeaways from some of these studies are, number one, that they're out there. So there's lots of trials that we're looking at this. The number needed to treat for a lot of these primary endpoints is pretty reasonable. So, 3, 6, 9 is not terrible, to the point where I think, definitely worth trying for many patients. On the other hand, looking at some of these endpoints of 30% pain reduction is important. So that is valuable for many patients, but it's also important to counsel that this is not going to be 100%, or it's not expected to be. So those other non-medicine interventions are so important, if not more important, because of that. Pregabalin and gabapentin, again, similar number needed to treat of 9. Cyclobenzaprine, a number of studies as well, with the number needed to treat of 4.8. SNRI, so I think a lot of us now are using duloxetine in this situation. Again, very similar evidence. Tramadol as well. SSRIs have a number of trials, again, pretty good evidence. And then I think important to note that NSAIDs, and really any mechanism that we use that's more on the nociceptive pain pathways, are not going to be effective. So opioids, same way, because of where the pain is coming from. Okay, and so again, sort of alluded to this, I was focusing on the medicine side, but really, and even in the guidelines, one of the first things they say is initial management strategies should be on non-pharmacologic therapies. And I think that that's so important. When I counsel patients about it, I say, really the pain pathway is complicated. Their symptoms are complicated, and so the treatment is as well. or I shouldn't say complicated, complex. It's multidisciplinary, and it's, and it has to be in order to manage this. And I think that that's really important for all of us to remember. Okay, so I've got a few minutes left. I wanted to end on a couple new sort of ideas. I was trying to think of a good sort of positive way to end, and I just picked sort of two areas that I thought there was some interesting studies coming out, and I thought I'd highlight those. So the first one is in JAK inhibitors in inflammatory arthritis, and then I'll talk about something in osteoarthritis as well. So again, going back to the mechanisms in rheumatoid arthritis, I talked about one of the nice things about my job is we have lots of things we can go after in inflammatory arthritis. And a lot of us are now becoming more familiar with some of the more common biologics. But one of the new kids on the block, not that new though, but it is newish, are called the JAK inhibitors. And so when we think about that whole inflammatory cascade, what happens is we make these cytokines that then communicate to the nucleus of a cell. So this is sort of the end kind of game for a lot of that inflammatory response that then goes out and makes the inflammatory proteins. So this JAK-STAT pathway is the target for something called JAK inhibitors. And just like all of the sort of treatments, they come out being compared to placebo or maybe another biologic to look for a response. And that's exactly what we saw in this study here, is that the JAK inhibitor is in green. It was compared to a TNF inhibitor, so a more long-standing treatment, and showing changes over time in patients responding, getting to a certain target in their disease activity. But what's a bit unique in this class of medication, or at least hasn't been studied in others, is its response on pain specifically. And that's not something that we usually use as an objective measure in clinical studies, even though, as I mentioned at the very beginning, pain is one of the most important factors for patients and clinicians. So what we actually see here is that the JAK inhibitor compared to placebo, but even compared to the more conventional biologic therapy, shows a difference. And I will say I've seen this, and my colleagues have seen this in this class of medication, that we're starting to see a bit more of that. Well, my pain is better, not just the swelling and the stiffness and the disability. And so to me, that means that there's more to learn about how pain in inflammatory arthritis works, and maybe ways that we can apply that knowledge to both inflammatory and maybe non-inflammatory conditions. And then for the last thing I wanted to talk about was a study that had come out in terms of osteoarthritis and hormone therapy. And the theory, or the thought, I guess, behind this being that we know that osteoarthritis tends to come on more frequently in a postmenopausal period. Now that might be coincidental because it's associated with age, but we also see it in patients who are put on hormone blocking therapy for cancer, that they get arthralgias and joint pain. And so it's sort of spurred the thought about using hormone therapy in treating osteoarthritis. And so this was a feasibility study. And before we get too excited, I will say that's all it is. It was just a trial to see, could we then make a bigger trial and really look at this? But they did have secondary endpoints looking at changes in pain. And so on the left, we do see that both placebo and this hormone therapy had a reduction in pain. But what's a bit interesting, for good or bad, is that when the medication was stopped at week 24, there was a rebound in pain in the treated group compared to placebo. And the thought there being that maybe there was an effect that was happening, that then when they went off treatment, they saw come back. Whether that's a good thing or a bad thing, we have to, I think, debate some more. On the right, though, we did see nothing significant. This was a very small study, but we saw some trends maybe to improvement in some of the pain symptoms. So it's another area that I think is kind of exciting to see if it shows anything, and it sounds like there will be more information coming, maybe some more studies in this area. Okay, so just to wrap that up, a couple points to take home, I think, is important to remember that pain is important for rheumatology patients. I think that's, I think everyone would agree with that here. Pain is very complex, but it is important to kind of identify the type of pain that patient is experiencing in order to best manage it, because you can have more than one type in different diseases. In rheumatoid disease, it can be from active inflammation, from chronic damage, or it could be from other etiologies. And fibromyalgia, can be involved in pain and other conditions or as standalone. So it can also be a part of rheumatoid arthritis and osteoarthritis. And there may be, well, I know there will be new treatments on the horizon. So always more to come. Thank you. I'll just end there. And I think that's where we're going to take some time for questions.